Hi, I'm Dr. Yusuf. I'll be presenting to you today this case of the intraoperative floppy iris syndrome due to Flomax, for which we needed to do to put the Malyugin ring, and we had a small complication from the J-Cannula because of the poor visualization. The case started as usual: 2.75 knife, viscoat, then the paracentesis, and then I'm going to implant the Malyugin ring. So the nasal is engaged first, and then I move it a little bit and tilt it superiorly so that I can engage the upper part of the pupil. So I retract it a little bit because it is missed, and then I rotate to the other side and engage the lower part, and then rotate it 90 degrees to not so that it doesn't hook it. So the trailing one is engaged, and then I'll refill the chamber using viscoat because we lose some of that, and we don't overfill at the beginning. So now we filled it. The capsule access started as usual. In the center, to measure about 5.5 millimeters in diameter. That's my target. This is followed by the hydrodissection, hydrodelineation, and nuclear rotation. So this is the hydrodissection, rotation, and hydrodelineation. The phaco started that as usual. This is the FX handpiece again with the on the signature ammo machine. I use the chopping all the time, and this is horizontal chopping. This is like a grade 3 cataract, so let's remove the same thing. In this video I wanted to show that the importance of visualizing the tip of the J-Cannula, because J-Cannula is very, very safe to use to do the irrigation aspiration or for cortical cleanup, but it can be complicated if the visualization is impaired or and the location of the cannula is not checked. So while I'm doing the phaco here, I'll start talking about that. What happened in this case is that the tip of the J-Cannula was actually on top of the capsular rexus or capsular bag, and it resulted in hooking the capsular. It hooked the capsular bag actually, and that resulted in a very small dials. Now this is the J-Cannula starting here. It's going very well, no problems. Doing the cleanup very well, but we'll see what's going to happen here. See, now it's in the area that I don't see. So this area here, I found that okay, this is not in the proper position. So I dragged it slowly so that it doesn't hook. I injected some vitreous in that area to dislodge any capsule or vitreous that was there, and I injected more of the Provis at this stage to implant the lens. See, even if we have this kind of complication, you can implant the lens in regular position. So I implanted the lens regularly in the bag, no problems, and I try to keep the haptic to in that direction of the small dialysis that resulted. So this way it will be in a good position. And try to decrease the manipulation as much as you can at this stage. So that you don't drag more vitreous to the front. So far I don't see any vitreous, so it's doing well. Making sure of the position is okay. I'm trying to test the lens, make sure it's in good position and it's stable enough. Here I'm going to take out the of the Malyugin ring. I start by dislodging the upper one first. You can see that the iris is very, very floppy. Okay. It It hooked unintentionally. This wasn't intentional. It hooked the hook and came out with it, which is not good actually, but that's what happened. Now it's in a good position to be taken out. You have to engage both of the parts of the ring to be able to get it out. Let's see the ring. The hook has to hold both of them. It came out well. Now I'll do the irrigation aspiration cautiously. But here I can see a small amount of vitreous fibers. So I'll do a little bit of anterior vitrectomy, just to be on the safe side, because there's a small amount. So you can, if you're in doubt that there's vitreous fibers, you can't do irrigation aspiration. You have to use the vitreous cutter to remove it. You can see that the pupil is central well and rounded well. I use the bimanual vitrectomy. The vitreous coming from very far from the nasal part, so it's okay to use the main incision. So I'm doing anterior vitrectomy. It's well centered, and pupil is regular. There's no major problems here. So despite having this small complication, still the results are good, and the vision had 20/20 vision after the surgery. I see the patient the same day after surgery. Results are good. I'll hydrate the wounds as usual using Avelox, which is the 4th generation quinolone. Injecting to the wound, both sides, and part of it goes into the anterior chamber, intracameral. Here I inject sideways on top of the iris to make sure that there's, in the IFIS patients, I inject it on top of the iris so that if there's any nuclear or cortical material hiding in the above the iris, it will come out. So you redirect your infusion so that you make sure that you clean up the chamber well. Thank you.